Welcome, everyone. Thank you to all of you who have joined us today for this insightful conference elective session. It is a pleasure to see such a diverse and dynamic group of practices interested in behavioral health, and I would like to express our gratitude for your presence here today and for your commitment to improving patient care. Your participation is what makes these sessions so valuable and the exchange of ideas that leads to progress and transformation in our field. My name is Christina, and I'll be moderating this session. I have a master's of public health focused on health policy and management from Columbia University in New York, where I'm based out of. I spent most of the last decade helping primary care practices just like yours prepare for and operationalize their workflows in preparation for value-based payment. I've spent most of that time focused on Medicaid, so today's session is particularly close to my heart. As we all know, behavioral health access and coverage is very important to these populations, so I'm very excited to hear from our featured speakers today. So today, as you know, we are gathered for a very special session titled Whole Person Health, a deep dive into integrating behavioral health for comprehensive patient care. The topic underscores the importance of holistic healthcare, acknowledging that physical health cannot be separated from mental health, and that a comprehensive approach to patient care is not only desirable, but essential. We're going to look at what integrating behavioral health looks like in PCF, and then I'll introduce you to your peer presenters. We'll then hear from St. Mary's Family Medicine, followed by Ann's Choice Medical Center, to hear about their approaches to integrating behavioral health. Then we'll end today's session with some time for question and answer. So feel free to put your questions in the chat throughout the session. And I already see folks are introducing themselves. Awesome. All right, let's dive in. So based on your responses in the 2023 Care Delivery Report survey, we identified that 89% of practices are already integrating behavioral health into their primary care services. 72% of these practices are relying on referrals for behavioral health care, and 54% of practices are tracking outcomes, a crucial step in evaluating the effectiveness of our strategies and making necessary adjustments. And then we have 15% of practices who have no enhanced strategies beyond referrals for behavioral health care. This brings us to the so what of our session today. These figures show that we have made strides in integrating behavioral health into primary care, and that there are different ways to integrate behavioral health into each practice. That's why today's elective session is so important. Our presenters will share strategies and tactics that identify strategies they use to integrate behavioral health for comprehensive patient care within their practices. So while your practice or organization might have different resources than our presenters, I think everyone attending today will be able to walk away with learning something that might enhance their behavioral health integration strategies. So without further ado, I would like to have our featured speakers introduce themselves. So John, let's start with you and Sheryl, and then we'll move to Maya.
Okay, thank you, Christina. Thank you, everyone. My name is John Marcelis. I'm been practicing clinical geriatrics for about 34 years, and I work with Sheryl as a VP in the company for quality and partner with her for value-based programs.
Good morning, good afternoon, I guess it's where you are. My name is Sheryl Alcorn. I'm one of the regional directors for practice administration for Erickson Health Medical Group, who works with Ann's Choice Medical Center. Again, as John stated, we've worked together for quite some time, and we do work on those value-based programs.
Yeah, hey everyone, my name is Maya. I would say I operate on the other end of the spectrum than my co-presenters. I'm an early career leader, so I'm in the first 5 years of my career. I'm a behavioral health consultant and run a program called the IMPAC program, which you all will hear about.
Awesome, thank you. All right, so Let's turn to St. Mary's Family Medicine first. Maya, can you tell us more about your program, the IMPAC program?
Yeah, absolutely. I'll start with just where I'm situated, the context I'm in. We're in a family medicine practice in Grand Junction, Colorado, and we serve about 75% either Medicaid or Medicare folks. So about 75% of our folks are Medicaid or Medicaid, Medicare. It's a rural safety net clinic, so we see a lot of high needs and social determinants of health needs. So there's kind of two parts in our residency. One is we have a robust training program for family medicine physicians, and then we also have a robust behavioral health consultant training program that I'm a part of. That program has 4 full-time staff, including me, 2 full-time postmasters and postdoc fellows, and then 4 MSW students. We partner with the local university. We're a level 5, level 6 SAMHSA integrated clinic, so we're extremely integrated. So I'm already operating within an integrated clinic, and actually came in as a fellow a couple of years ago, and then we got this grant to set up this program for basically our most high risk, most complex patients. So that's who I'm talking about today. Is a kind of a program within a behavioral health program where we set up the ability to conduct wraparound behavioral health care for our most complex patients, the patients who were, even though we have already a robust behavioral health system, who were still falling through the cracks, who weren't getting the help they needed, and who ultimately were high needs, but not being met by the services we had in our clinics. So we created a program that ultimately is looking at evaluating how we can reduce ER utilization for this population. That's a huge driver for a lot of payer systems. So that is kind of the outcome that we're measuring. What we do is a combination of inpatient services, outpatient services. We kind of help people transition from the hospital to our clinic, which is one of the places where we saw the biggest gap in transitions. We also do home-based services. So we were finding that for our most complex patients, it's really complicated to ask them to come in on a scheduled basis. Their lives are extremely chaotic, and they needed more flexibility in a system that's pretty rigid. So we set up home-based visits. We'll meet them in parks. We'll meet them in mobile homes. We'll meet them anywhere they need to be. We'll even go to homeless shelters if that's where we need to meet folks. We will also do medical accompaniment. So our goal is to really integrate their care between specialty care, between their dentist, between their primary care clinic, and really house everything in their primary care clinic. So we'll do integrated teams, maybe with psychiatry, set up meetings with their nursing home to really kind of coordinate care with them as well. And our goal with this program was basically to create a flexible system for our most complex patients within this kind of rigid healthcare system that we're all kind of operating in. We do individualized treatment plans. So every patient gets their own treatment plan that's communicated through the EMR system through to their PCP and to whoever else is on their care team. Our goals were really to help rebuild trust in the medical system, help them feel like primary care can be their direct contact and they'll get their needs met. And to just meet them where they're at instead of kind of these more overarching driven treatment plans that are not applicable to their daily lives. So we started out with just working with a small population and have expanded since then. We try our best to have every patient that comes through have a team meeting about them. So we might meet with the MA that sees them most often, with the PCP and another provider that might see them most often, and then their psychiatrist. However we can, we're pulling in to make things more integrated. One patient example that I wanted to bring up was just one patient that had gone to the ER, I don't know, for all of their care seemingly, since they moved to our community. They were experiencing loneliness, isolation, didn't really understand what their medications were for or why they were using them. We just created a care team weekly with that patient. We tried our best to get them into clinic, but we would use virtual options if not, and met them where they were at if they needed to. We actually got them engaged in our group cooking class here. They started improving socially. And then after about 6 months, we started to see a downtrend. They started to rebuild trust in the medical system. We started to notice that things that we weren't even working on were starting to improve. So we didn't even target blood pressure specifically, but their hypertension has dramatically improved. Actually, they don't even qualify necessarily, don't even have to take medication for it anymore. Things like A1C are dropping as well with not just this patient, but other patients. So things that we're not even targeting medically are dropping just based on our ability to kind of meet the other needs that are surrounding this patient or these patients. And then ultimately what we see is a reduction in ER visits and an increase in family practice visits for their care. Can I go to the next slide? Yeah, I can. So we found some pretty good outcomes. This is some pretty preliminary data. It's not an IRB approved study. This is just quality improvement projects studies we're doing. But among our very tiny sample that we initially started with, we saw a huge decrease, 66%. And it was statistically significant despite such a small N. We also found in some of our data that we did a t-test that showed that the longer people are in our program, so if the data was collected between 2 and 11 months, so if they're in the program for at least 2 months, the longer that they're in it, the more significant their ER usage will drop. Up to about a year, we haven't been able to collect data past that. We also had our interns do a qualitative study, and we found that the 3 most common improvements that people pointed to were that they had an increased cohesion in their medical team, and that they actually understood their medications, their treatment plan, and what their goals were, and they felt like those were aligned with their primary care provider for the first time. We actually had 100% of people say that their healthcare needs were better met after the IMPAC program. The kind of next steps, there we go, we actually just launched inpatient BHC service. So we're actually going to the inpatient hospital twice a week to meet patients there. We expanded it not just to high utilizers, but to anyone with any sort of health need. And then we have introduced the intern program. So we're actually training MSW interns at a local university in kind of high complex care, high utilizer. We even did a program coordinating with the nursing team over at the university. So we're trying to kind of work systemically as well to address how to care for these folks with students. Our biggest kind of issue is this is very inefficient work. I'll be honest, right? The reason that it didn't work in our normal behavioral health program is because we have cancellation policies. We don't have any of those type of policies because we're trying to capture people who have such complex lives. It makes the work inefficient. It doesn't make it not worth it, in my opinion, and in the opinion of our value-based care payment model. That's pretty much it. We're gonna continue building it. We built a tiered program so that we're working intensively with a small number of people, but then we're kind of expanding our services by going out and out. by having more and more people around. I'm happy to field questions and pass it along.
Thanks so much, Maya. Yep, folks can definitely drop questions in the chat, and it's just really inspiring, I think, Maya, like you said, all the work that you're doing to really meet patients where they are. So thank you so much for that overview. I would love to turn now to Ann's Choice Medical Center. So John and Sheryl, could you tell us a little bit more about your practice's approach?
Absolutely. And I think what we'll do is just start off a little bit about us. We are very different. We are part of Erickson Health Medical Group. We actually have 19 different retirement communities and independent medical centers that are within those retirement communities in our independent living structure. In addition to that, we do serve patients in memory care, assisted living, long-term care, and skilled. We have approximately 19 campuses wide. We have about 175 providers who care for about 30,000 seniors in 11 different states. We focus on person-centered care. Our providers would include physicians, nurse practitioners, physician assistants, podiatrists, mental health nurse practitioners, behavioral health clinical specialists, and licensed clinical social workers. Our campuses are large. The campus that we're talking about today is Ann's Choice Medical Center. It is located northwest of Philadelphia. It is the one that is spotlighted on the poster that you will see later on. John has been, and he's going to speak a little bit next, but he has been the medical director there since its inception in 2003. Ann's Choice itself has about 2,000 seniors, and the average age of those seniors is 86. 1,800 of those patients are independent. The rest of them live in long-term care, skilled, memory care, assisted living. Okay. Ann's Choice has 5 physicians, 2 certified registered nurse practitioners, 1 podiatrist, 1 mental health nurse practitioner, and 1 licensed clinical social worker. Our providers are available 24/7, 365. They are on calls nights and weekends. Erickson Health Medical Group itself has participated in several of the Medicare initiative programs to include CPCI, the original comprehensive primary care, CPC Plus. We also are working with Maryland Primary Care and, of course, PCF since 2021. That being said, I'm going to go ahead and pass it on to John, and he will talk a little bit about how we have integrated behavioral health into our practices.
Okay, great. Thank you, Sheryl. It's good afternoon, everyone. It's important for us to tee up the practice. And by the way, Maya, it's an awesome job. Fantastic work that you're doing. Keep it up. So I'd also like to thank our PCF partner, everyone else who helped put this thing together. And hopefully we get a few tidbits out to those who have joined us today. So let me give you a little bit more historical perspective. And we are different than what Maya is doing at this point. But we're similar in that we found that a long time ago that addressing and meeting the needs of our residents, and we call our patients residents, just in case you hear me say that over and over, in terms of maximizing their quality of life, we really found the need to focus on their mental health needs. Now, as we know, mental health is a major determinant of wellness and healthy living for all ages, for all socioeconomic strata, but especially for the geriatric population that we serve. And as Sheryl said, our patients are not the young old. We take care of the old. The average age resident is about 86 years old that we take care of. And, for seniors, as they journey through their aging process, there are challenges with adjustment, loss, anxiety, depression, sensory cognitive decline. And all of these challenges not only affect the resident, but their family and their caregivers as well. So way back 2 decades ago, in about 2004, 2005, we had already hired a full-time RN clin spec in behavioral health, recognizing this need. As our clin spec retired, we found that the discipline was being sundowned, and we moved over to a mental health nurse practitioner to fill that role. And we've had that nurse practitioner in our practice now for several years. and she partners with and she has a symbiotic relationship with her LCSW, which is what we're here to talk about. So around 2020 timeframe, as CPC was drawing to a close, and we anticipated acceptance into PCF, we did consider adding an LCSW to our team. So thinking of the why of it, I mean, we really felt that the licensed clinical social worker would add a new dimension, new optics, away from the traditional nursing medical model and a more psychosocial perspective. We recognize that our residents frequently have very complicated family dynamics. I'm sure we've all had to work with those, and some other, and or some social determinants of health that may be impacting them. So we did hire our first time LCSW, and that was around 2020. And she's been with us ever since. Another point is, in terms of the why of it, we recognized that many of the challenges that our residents faced were really complex and labor intensive. A lot different than what Maya has with her resident population, but certainly in many ways, they were complex and labor intensive, and they did require a significant amount of resource and expertise to build out a plan. So bringing in the LCSW onto our team allowed our medical providers the bandwidth to more effectively and efficiently deal with those medically complicated cases that had significant psychosocial overlay. So best and highest use of our time and licenses for all of us. And of course, this was a huge value add back to the residents. So let's take a look at number 10 slide, which I believe is up on the deck. That's the first of three for us. I think we need to go back one. I think I'm showing okay. Yep, there we go. So it's a little complicated, and I'll try to chunk it out so we can get through it. On the left-hand box, we see stress management and resiliency training. For those of you who are unfamiliar with this program, it is an awesome program. It's out of Massachusetts General Harbor Institute. I'll put a disclaimer on it. I have no relationship with them other than the fact that I've attended the course, as have many of the providers in our company, and it is awesome. And it basically teaches you the value of meditation, breathing, and resiliency exercises that you can translate into your day-to-day. And our newly hired LCSW not only completed the primary program, but she went on to further educate and is now fully accredited and is doing one-on-one and group sessions with our residents and staff. So you can see one of our indicators further along, where that comes into play. The middle box is care huddles, and every day, Monday through Friday, 8:15 a.m., our core team and extended community service providers join in a huddle. And it was in person. It's been virtual since COVID, and hoping to get back to in person very soon. But in this huddle, we discuss relevant resident activity that occurred in the previous 24 hours. Anything that we can anticipate for the day is also discussed, and then we discuss and prioritize as a team some plans and goals for the day. On the third box to the right, labeled patient and family meetings, our LCSW is a critical member and integral to our patient family affair council meetings. And we meet quarterly with our residents and their family members, children, to explore opportunities for our practice to improve. And her psychosocial lens at this meeting adds enormous value, both from our perspective, but also from the residents' perspective as well. At the bottom of the slide, you'll see a couple numbers. Now, although depression screening is a team effort here, our LCSW really is the champion of this. And we noticed when we recognized that we did 940 depression screens in 2023 using a PHQ-2. If that triggers, we do the PHQ-9. And that's a 28% increase year over year. And a lot of that 28% increase is related to the addition of the LCSW. Okay, let's move on to slide number 11. That's the second in the series of two. Oh, thank you for doing that. Couldn't get my cursor down. All right, thank you. So this slide also is a little bit busy, but not quite as the previous, and we'll be able to chunk it out and get through it as well. So on the left-hand side, looking at outcomes, one of the things we look at is advanced care planning. As we know, in an average age patients who are 86, it's very important to have advanced care plans and work with the family and understand before a catastrophic event occurs, really what that resident wants and what is right for them in that particular time in their life. And our LCSW is the champion of the end-of-life education. She is the expert in reviewing and teeing up the pulse for the residents. And she does this one-on-one and through community outreach. Moving over to the next slide on the right. In 2023, in a 6-month period, we measured a 22% decrease in sedative hypnotic anxiolytics in our patients. I'm looking at those patients who had it on their medication list. Now, this is a team focus. The providers are laser focused in on it, but our LCSW working with the residents, frequently utilizing the SMART program techniques, meditation in lieu of medication, has allowed alternatives to residents away from sleep agents and using meditation, for instance, and some breathing exercises to get through the night to initiate, and then if they were to wake up, to reinitiate sleep. So we see a significant reduction in those medications. And as we all know, these are not great medications to begin with, but especially not in those octogenarians that we take care of here. So that was a major win. The 9% down, and this is a decrease in avoidable emergency room transfers. And we really do have a focus again as a team on minimizing and reducing unnecessary transfers. It's a group focus. But our LCSW leads our high-risk team meeting. And this, the huddle is a once a day, 15-minute TOL per day. Once a week, though, the LCSW leads a meeting looking at those high-risk patients who are within our practice. So they're identified, they're discussed in an interdisciplinary manner. These are the residents who are really identified as being on the cusp of either requiring more care or possibly needing to transition to a higher level of care. So she guides us and keeps us in front of this, putting together a service plan as an interdisciplinary team. The other thing she does in that meeting is she tracks all of the residents who go out or come back from the emergency room. And we know that that is an extremely high-risk transition for our residents. So those coming back from the ER or coming back from inpatient acute services back onto our campus, those are discussed at that meeting. She makes sure we work together as a team that all the necessary services are in place to minimize their risk and to hopefully keep them from going back to the emergency room or worse yet, being readmitted. Okay, let's go to the last slide. And so here we are. We're looking ahead, lessons learned, and next steps. So in terms of the LCSW, lessons learned, is that in addition really to just her general counseling service, which she does in addition to everything else that I just mentioned, the addition of the LCSW really has given us a more holistic approach. Her mastery of the SMART program techniques, building efficiencies into the practice, leading our high-risk team, participating in critical clinical quality initiatives, reducing sedative hypnotics, reducing unnecessary ER transfers, completing depression screening and advanced care plans are all a huge, huge value add. And so where are we going? Well, we'll continue to grow out the aforementioned programs, quite a few as I just discussed, but we're always looking for additional innovative ways to enhance our care model and promote wellness. So one of those things, which I think is really cool, is a pilot at a couple of our sister communities looking at a comprehensive plant-based healthy diet menu for our residents. Not just options, but really a full array of plant-based alternative food services. And once that comes into play, I really anticipate our LCSW will have a significant role as a champion in education and bringing this initiative forward as well. And finally, another real exciting thing, and I actually completed my first one yesterday, Monday, is a comprehensive cognitive assessment program. So residents that we find maybe having some early cognitive decline. Sometimes it's hard to pick up early, but if there's signals, then our LCSW will meet with the family. Sometimes it's a self-referral, sometimes it's a referral from the providers, but you'll meet with the family and the resident. She'll construct a detailed social history. She'll administer tools for measuring cognitive ability, depression, caregiver burden, stress, IADLs, ADLs, vulnerability scales, advanced care plans. She'll bundle all of that, and then it's coupled with a full medical evaluation looking for perhaps reversible causes of dementia. And then the resident comes back for a meeting, and we talk in that meeting. We educate the family, we discuss our findings, and we put together a short and a long-term game plan to maximize the quality of their life and to better understand what may be ahead. So that's kind of what we do. It's an awesome, it's an awesome way of caring for seniors, and I certainly feel blessed every day to be able to come in and just be a small part of it. I will pass it over.
Thanks so much. Thanks so much, John. I love that meditation over medication. That's a beautiful sentiment for primary care. And thank you to all our featured speakers. So we're going to turn now to the question and answer portion of our session. So feel free to drop your questions in the chat, and we will select them as you all submit them. But just to start us off, Maya, do you have an internship schedule or goals list for your Masters of Social Work intern program?
Yeah, we do. We try and highly specialize it, but our overarching goals for our interns are to develop behavioral health skills for working with complex patients in a healthcare setting. And then the skills that we aim to train them in are intensive case management, trauma-based therapy, crisis management, and then managing integrated care teams. And we have developed a semester by semester objective list and goal list for our interns. This is our second round of interns, and they actually have signed on to a second year. So we've decided it's been so successful, which has been really cool. We've decided to kind of create tracks. So one of the interns is doing a research track within our IMPAC program. So they're going to be specializing in kind of data collection and doing all of that part for the program. And then our other intern is really interested in SDOH metrics. So they're going to be doing SDOH needs assessments, communicating through the EMR system, and figuring out a way within our EMR system to kind of input that data so that everyone who sees them might be able to address that from a different management style. So we're having feedback constantly from the university and kind of meeting in teams to figure out what works best for the interns. But yes, we have a schedule, we have objectives. It's highly structured, which we find is the most helpful for really lending legitimacy to a pretty new program.
That's great. The next question we have is for you, John and Sheryl. You talked a little bit about your LCSW. So is that resource administering the depression screenings directly? And then, can you talk a little bit more about the comprehensive exam that you all have them doing?
So we do, as a normal part of our follow-up visits, the PHQ-2, all the providers, including our LCSW. If a resident is referred to her for a specific issue, she will, many times, it'll be the first time that it's done, or it hasn't been done in a while, she'll repeat doing it. So it's kind of a team-based. We do it together. She certainly does a significant portion of them, and I would say pretty much with every one of her encounters, initial encounters, and probably on an annual basis, she'll redo a depression screening. So team effort, she does a significant portion of that, however.
Awesome. That's really wonderful that you all have been able to bring on that kind of support. Flipping back to Maya, have mobile behavioral health clinics been a part of your integrated teams?
Cool. I like that question. So we are in a sense a mobile behavioral health clinic. We go inpatient and we go outpatient. We also go into patients' homes, into the community garden with them. We have created it to be community-based. Now, what I would love to see and what I'm partnering with our community health center, we don't have the capacity here in our clinic, but our community health center is trying to create a street team complete with a case manager, complete with behavioral health, even a physician attached to it, and maybe getting some of our residents some experience to go out into the community, specifically working with our homeless population. I'm more of a consultant on that, not really part of the IMPAC program specifically. But we do have our residents work in a day shelter where they get tons of experience working with high needs homeless patients. And then we have a behavioral health professional go along with them to kind of coach both the patients and the residents on how to provide better, basically street care. And we've found that those are really highly successful programs. Yeah, I love that question because I think that's the answer, honestly, is to go meet people where they're at in the community.
Yeah, absolutely. Thank you. Our next question is sort of for the group, so feel free to answer in whatever order you'd like. But can you talk a little bit about how each of your practices uses and receives data to inform integrations of behavioral health with primary care?
Yeah, I can go. So for our referral system, we started out purely using kind of data-driven models. So we used attribution reports from insurance company. And then we also use our own internal EMR, electronic medical records, risk reports. That's how we started. And we've actually drifted away from that for referrals from providers and from our psychiatric evaluation team in the hospital and from care coordinators or CAN managers seem to be a lot more fruitful in response. And then in terms of how do we use data to inform integrations, there really aren't a lot of evidence-based models for therapy with high risk complex patient populations. There's really not, right? Things like EMDR, things like pain reprocessing therapy, all of these models that are really awesome and incredible are mostly tested on highly educated rich folks, right, with trauma, which is super amazing. And that's not our population. And so we don't have a lot of evidence-based models that we're using. My goal ultimately is to create one. And that's kind of what we've been doing. That's why we have such a flexible program to kind of meet patients' needs where they're at. And I think that ultimately is going to be the answer, is some sort of flexible therapy, right? Combination of narrative, solution focused. So if you're talking about evidence-based therapeutic models, we really don't have one. But we are constantly using the data that our practice puts out to inform how we interact with patients as much as we possibly can.
John, Sheryl, what about you all? How do you use and receive data to inform your integration between behavioral health and primary care?
I thought, Sheryl, you would pick up on this. So we are a data-driven company. Most of the data that we have is internal. We have a dashboard which we measure lots of different factors, from preventative measures to utilization measures to administrative measures. Things that we value for our residents, which may not be thought of in other practices, is the percentage of calls that are answered within 10 minutes. And we know across our enterprise that 95% of them or more, probably 100%. Most of our campuses are within 5 minutes. We have humans pick the lineup. We don't have hit a button here, hit a button there, hit a button here, because we know these people can be impaired with their hearing or their senses. So we look at measures similar to that, again, using internal data. Recently, we're looking at, and we've just added to our dashboard a measure that looks at the number of phone calls that go to messaging versus the number that are picked up by live voice during normal hours. And we're 95 or 93% on that as well. Again, because if you're a senior and you're calling in and you get a line, you get confused by it, you leave a message, no one gets back to you, you're going to pull the cord and handle up to the emergency room. So we look a lot at the ACOVE measures and measures that are specific to geriatric patients, and we build them into our day-to-day, and we present them every 4 weeks at our quality measure meeting to all the medical directors, and then splay it out to the providers. So that's where most of our data comes. It's internal. We do compare it to national models, and there's many other measures as well. Any other, Sheryl, that you can think of that may be relevant to this discussion that you want to talk on? Sheryl and I partner on this dashboard amongst many other things that we do.
Yeah, I can't think of any off the top of my head. So some of the data obviously is in the EMR, and some of the data is with our corporate partners, and putting that data together. So John, I think you mentioned them. I think our on-call rate is one of them that we look at, obviously trying to keep them out of the ER. So we have a different model. I probably should explain that. Like I said, we have on-call providers, but we also have security EMRs on site. And so they're our first responders. So if there's an urgent issue, an emergency, they're pulling the cord in their apartment or anywhere throughout the community. So we look at our response rates to our security partners, and are we appropriately sending them out or not sending them out? And are we actually meeting with that provider before we make that decision of sending them to the ER? So yeah, that's what I can think of at this point. Yeah.
I just wanted to add on one thing. After hearing all this great evidence-based practice that people are doing, in terms of actually using data to inform integration, one of the things that I hope everyone is using and thinking about is the SAMHSA level of integration. If you haven't looked at that, I would look at that document. SAMHSA put out this there are 6 levels of integration for integrating behavioral health into primary care. And that's kind of the gold standard for how you integrate. And so we use it as a practice to kind of, as feedback for ourselves. Where are we at? We're a level 5, we're working on level 6, our EMR systems are communicating together, right? Like, so we're kind of using it as not only a model to base off of, but also to provide ourselves feedback. So I would recommend at least sitting down with your practice and looking at the levels of integration and seeing where you're at, and then what you might need to do to increase your integration level. And you might not be able to, and that's okay, right? But it might be a helpful tool.
That's great.
Yeah.
Another question for the group: how have flexibilities in the PCF model supported your efforts in implementing your respective programs? So again, whoever wants to jump in first.
So I think, if you think, there's a lot of different, but kind of speaking to the point, the LCSW position is different than the mental health nurse practitioner's position. The mental health nurse practitioner spends the majority of her day in counseling sessions, doing one-on-ones, billing for fee-for-service for what's relevant for her practice. The LCSW, a significant portion of her time is spent in other activities outside of one-on-one, doing psychotherapy or CBT, or other things that our mental health nurse practitioner may be doing. So that's non-billable service. And I think PCF has given us, through their reimbursement structure, the ability to fuel and be able to have an LCSW be able to do a lot of things that we discussed, spend our time working through the SMART program with the residents, doing community outreach, running the huddles, running the high-risk team, things that are non-reimbursable medical services in the traditional way, but certainly give a huge value back to the community. And then PCF has actually given us an opportunity to do that.
Yeah, I think I'd echo everything John said. Value-based payment just makes sense for complex patients specifically. I think when we try and like systemize everything, it becomes too rigid of a structure for a lot of patients who have too complex of a life to be able to fit into that rigid structure. So value-based payments allows providers to kind of just worm their way through a treatment plan at the best of their ability with what patients come up with. Patients aren't coming to us and saying, I want to lower my A1C by 3 points, right? What they actually want is to go to a barbecue with their family on Saturday, in next year. And so we can actually work towards that. And what happens is that when we do that, things like A1C, like blood pressure control, those all end up in line because their lives are better. So I think when we allow people to do what they do best, it usually works out. Hopefully, we've found it does.
Yeah, absolutely. Again, just really reiterating, meeting patients where they are, trying to target what is actually important to them and not what we need to see for reimbursement purposes. One last question. We have just a couple of minutes left. Maya, you had mentioned EMDR in the Q&A section earlier. So can you just talk a little bit about how have trauma assessments been integrated into the programs? Are there trauma screenings that PCPs administer, as well as whether there's education to providers on the impact of trauma for medical issues?
Yes, and yes. So on a patient level, we do have EMDR providers in the clinic who we can refer to. I'm working on getting all of our staff trained in PEPC. It's a VA model called Prolonged Exposure for Primary Care. That's really short trauma-based model. I think it's the future for primary PTSD and primary care. So we utilize that. We also, because we're a training institution, our residents are constantly learning. So they go through a whole behavioral health curriculum. And trauma is inevitably a part of every single conversation in that curriculum. We also most recently did this really awesome, kind of big workshop with nurses who are training and social workers who are training. And we kind of had them swap roles and figure out how to deal with trauma from both sides, from a nursing perspective and a social work perspective. And I think programs like that, where we can just be creative and helping our future leaders and our future kind of students working on integrating trauma into every aspect of their care, no matter who they are. I think that's the biggest impact that we can have. Yeah.
Absolutely. All right. That about ends our time for today. We will post additional resources in the chat, and please do check out both St. Mary's and Anne's Choice posters in the posters tab on SpotMe. Thank you so much to our featured speakers, Maya, Sheryl, Dr. Marcelis, and all of the attendees who joined us today for a great discussion. Your engagement and your thoughtful insights have significantly contributed to the depth and richness of this discussion. Before we part ways, I just want to remind you to complete the short poll related to this session. Your feedback is super critical for us to continually improve and create events that address your interests and needs. And up next, we have a 10-minute break, and then you are invited to view posters on the SpotMe platform for a poster walk. And if you're interested in a strategy that a practice has implemented on a poster, leave questions and comments for the poster authors. Otherwise, we'll see you all back here tomorrow at 11 a.m. Eastern for our Day 2 plenary centered on care, reflecting on primary care transformation and the journey ahead. Thanks so much, everyone.